With us today, Adam Boyce. Adam is a firefighter, paramedic. Been working with us for a little while now. Welcome, Adam.
Hey, glad to be here.
Tell us a little bit about yourself. Years of service, what you did beforehand, whatever you feel comfortable talking about.
Okay. Well, I've been on Waterloo Fire for 3.5 years now. Before that, I was a paramedic for Mercy One. Before that, I was a student at Kirkwood, where I did a associate's degree focusing on paramedicine. And came out with a national registered certification, paramedic, NREMTP, and an associate's degree from there. Before that, Waterloo West, graduated in 2014, and pretty much been in Waterloo all that time except for the 2 years at Kirkwood.
Awesome. So, hometown kid.
Yes, hometown.
Where else did you test? Anywhere?
No. Funny story, I actually was kind of uncertain about what I actually wanted to do. Liked mathematics, liked science, was thinking about engineer, possibly at Ames, but in high school I was very indecisive. And junior year, my mom finally had enough of it, cornered me, and forced me to say right off the top of my head what I wanted to do when firefighter came out. Mm-hmm. So that's what actually got me going down this path. And talking with Waterloo personnel, they said, get your paramedic and then test with us. And Waterloo was the only place I tested.
First?
Second.
Second?
I tested in the middle of the paramedic program. Mm-hmm. So came back for a week, a couple weekends.
Right.
Made it all the way to the oral interview. Mm-hmm. Did not make the final list from there. But learning experience.
Absolutely.
And second time, much better outcome.
Right. Absolutely. That it can't be stressed enough that as you test, it's a learning experience. It's called a test, but it's really a class. It's really a lesson.
Mm-hmm.
All right. So you graduated with your medic. What year?
2016. I got it in June of 2016. Took two tries at the written, but I feel like that's pretty common.
Oh, I'm sure it is.
Especially with how the test is specifically structured. Right. It's an unconventional test, just in the nature of how they ask the questions, varying levels and everything. But did that in 16 and June of 16, stayed down in Cedar Rapids to finish up like a job. They asked me to stay for the summer, so I did. And then I came back, and about 2 weeks after I was back in Waterloo, I started working at Mercy, then Covenant, now it's Mercy One, right, in their transport ambulance department.
Their transport ambulance service.
Primarily, yes.
Yeah, if Waterloo Fire Rescue is completely pounded, then the Mercy ambulances will come in and act as 911.
Yep.
It's pretty rare.
Yep.
And now that you wear the blue shirt of Waterloo Fire, you have probably, like everybody, hold kind of a badge of honor with that.
Yes. It's almost a goal is to not give up your calls in your territory or your city to somebody else. So it's when you're ready to go back in service, because there could be one. And, well, even when I was at Covenant, working for Mercy One, if Waterloo was stretched thin, just boom, 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 multiple calls. I was ready, and I think I only actually did maybe 4 or 5 total in the entire time I was at Covenant for 2 years. So it doesn't happen very often. Waterloo definitely jumps on their calls.
Right.
So,
which do you prefer, the 911 service or the transport service?
Having done both of them, I enjoyed both of them for each individual parts. 911, there is a little bit more excitement, high adrenaline. I'd say I'm a very adrenaline-driven person. I do like the challenge of pretty much paramedicine in general. But to contrast that, the transport, it's a lot more mellow, but it's also higher thinking. You're dealing with much more sick patients. All the patients that are being transported to a higher level of care from our facilities in Waterloo, Mercy One and Allen, going down to the university where they have much more specialists. They handle much sicker people. So typically the people that are going down there are sicker. They do have more underlying conditions, and there's more to think about. So it challenged me intellectually on that front of keeping up on studies, knowing normal lab values, just reading patients' charts in the transport down, just seeing what different conditions and what medications people are on. So it was a learning experience. Straight out of medic school, it was a little bit much, especially where transport primarily, it's paramedic EMT. So I am the higher level, more experience, more knowledge and training. So to kind of cast me or put me in those situations, it was a little bit much, but it definitely gave me motivation to strive to use my skills and be the best I could be. So it was a great spot to start.
Yeah. So you took a different path than I did. I was hired on at Waterloo Fire Rescue and then went to paramedic school. So I've only known the 911 service. As my time as a medical officer, I got to train in our new medics as we got them. And I would always notice that with anyone that came off of a transport service, their medication knowledges were beyond mine at that point already. Their understanding lab values was always more than what I did, because in the 911 aspect of it, we see them for maybe 20 minutes total.
Yep.
There's you don't worry about those things in that minute part of time, whereas with the transport, what's it take to get to Iowa City from here on a transport?
Iowa City, 89.6 miles from the door to door, and it took about an hour and 20 minutes. Mm-hmm. The total round trip was on average about 3 hours.
Right.
So you could kind of march out your day, 12-hour shift. It could be 4 Iowa City calls. It happened multiple times where you throw a Rochester call in there. Mm-hmm. That was another common facility. But the amount of time that you spend with a patient is considerably larger. A lot more trending vitals, mm-hmm. where Waterloo you have your initial, and then depending on call type and severity, you might have a second or a third, but you'll never have any more than that.
For a lot of people, Iowa is rural. There's nothing in between. We're pretty blessed where we're at because we have
Extremely.
Two great hospital systems, and we're also 89 miles from Iowa City. The University of Iowa is. And then how far is it to Mayo Clinic?
I think 112.
Right.
I believe. Most of the time I was in the back, so I just never really had to radio in the hours or miles. But it was I think it was 112. Mm-hmm. Give or take.
Yeah, that sounds about right. The just having those two major facilities that close to us is a phenomenal benefit to anyone that lives in the area.
Well, and it always blew my mind that University of Iowa is known as one of the top research hospitals in the country, and then Mayo is known internationally. Right. They have an airport where they have people flying in from other countries for doctor's appointments and then go back to the airport and fly home in private jets. That whole aspect kind of blew my mind about how those two facilities are so close and how our surrounding area is extremely well protected in the event that you have a serious situation. You have experts that are within a drive's away.
Right. Probably a lot of our conversation is going to be as far as Waterloo Fire Rescue and the paramedic program, how it is now with you and how it was just the decade ago that I did it.
Yeah, the contrast.
The changes are phenomenally different. I see so many. I always thought I was a pretty good medic, but the number of saves I see today, that percentage has got to have increased exponentially from even when I did it a decade ago. Mm-hmm. We're not talking about, I don't think we're talking about the Middle Ages. We're talking about 10 years. We're talking about 2012.
Yeah.
One thing I think that always stands fairly clear, though, and stays static is I always felt when I was training new medics that you had to be a 3-tool paramedic. And what I meant by that was you had to have 3 tools that you will use on every single call. You'll have people skills, you'll have your pharmacology skills, and you have your technical skills, your hands-on things. I felt that my 2 strongest ones were my people skills and my technical skills. My pharmacology was always the weakest of the 3. Mm-hmm. Is that still a valid concept now?
I feel people skills is becoming stronger and stronger. as the field kind of progresses, unfortunately, 911 to a lot of people is not necessarily the last call they make. There's a lot of people use 911 to call for anything. Like if something's wrong, like a lot of people experience can attest to, this isn't worth a 911. Like the example stub toe, that it does happen, but just people's problems. Like people call 911 because they have a problem, and just having the people skills to communicate how we can help them, because they called 911, they need help, so we're there to help,
right.
Whether it be medical or something else, because it happens, and just knowing the skills and how to communicate best with that person, because most people call 911 on the worst day that they're having ever.
Right.
So it's also addressing and how to be sympathetic and empathetic to the situation to get the best outcome for you and the patient.
Right.
So, and then on the technical side and the technical skills, I was never too concerned with, because I learn better with my hands. So I pick up those skills much more quickly and get them to where I'm very efficient with them. The literary side with the pharmacology, that still takes work. I still have to review those frequently. But maybe another aspect that I would probably add would just be patience in general. Patience as being patient, not
your client.
Not the person, but just being patient, because hastiness, I feel like, has definitely hurt me in the past, and that's one thing that I've needed to work on. Additionally, beyond pharmacology, technical skills, and communication, because definitely coming out of high school, I definitely lacked people skills. That was a skill that I had to work on, because even coming straight out of EMT, I knew what I needed to do on paper. So scene safety, PPE, and then just go down the chart: primary assessment, secondary assessment, and communicate. Communication was always kind of on the wayside. Like, yeah, you needed to do it, but when you're actually thrown into it, people skills definitely showed that I was lacking in that, which I'm grateful for all the opportunities that I've had leading up to it, because I definitely feel like my communication and people skills have greatly improved, especially from Waterloo, with the wide variety of people that we have in the community.
For sure. One of the things I think that I will probably never lose from my time as a medic, and I'm sure you'll never lose as well, is you can walk into a room and you can almost immediately know sick or not sick.
Absolutely.
Talk about what sick, not sick means.
So, as paramedic, typically we get the call and we're heading towards the scene, we're given the information of age, sex, and then the chief complaint. Chief complaint is why they called. It can be chest pain, shortness of breath, psychiatric problems, traumatic injury, cardiac arrest, and everything you can pretty much think of. Dispatch likes to put it into a group, and then based on that, any paramedic has protocols that are put out by the department, state, national, of how to address that. So that's just kind of what you're doing on the way to the call. But as soon as you make eye contact or you see the patient, it does break into, instead of all of these lists of what you could do that you're thinking about on the way there, you see the patient and you immediately decide sick, not sick. Sick is, all right, this is not a communication first type of call. It's get the patient, assess them, and get them moving, versus not sick, where communication, where you talk with the patient, get more information about what's going on. And the easiest way to tell sick, not sick, is with the ABCs. So airway, breathing, circulation. Are they awake, first of all? Are they talking to you? Are they talking in full sentences? Are they unresponsive? Is there blood everywhere? A pretty good way of telling sick to not sick. Probably the biggest, I wouldn't say biggest, but the easiest indicator is if you see the patient's face and there's immediate panic on their face, that's a sick patient. So whether or not that panic is, in the paramedic's mind, legit or not is completely separate. That comes from experience, but once you have experience, you can recognize a sick patient across the room very quickly, and then moving forward, doing what you need to do. Sick, not sick definitely changes the speed at which you handle yourself on the call.
And I always think back again to my days of, it was almost instantaneous, and it was always almost instantaneous with both myself and whoever my partner was at the time of that sick, not sick person. Very rarely, and I can't think of any specific examples where I thought sick and my partner thought not sick, or vice versa. It's almost I'm sure we're doing a horrible job of explaining how it really is.
Yeah.
But it's absolutely, you hit that stride in your medic career where it's no longer a question. You do understand what's going on.
Yep. And that comes with experience, like bring up the partner where you're on the same frequency, where like you both see it, and then everybody reacts according to, and everybody's used to each person's rhythms and stuff like that. And the recognition with time, partners or even just people I haven't worked with very often, but we still recognize what's going on and change the cadence to a sick patient call. So, and yeah, that definitely takes time. Individually, I'd say it's almost more of an individual, but like specifically on Waterloo, we have a lot of good medics, and they can recognize sick, not sick, almost very quickly and pretty efficiently and pretty consistent across the board.
And I think, so Waterloo has had the medic program since the mid-'80s, mid to late 80s, I believe, is when we started to have the ambulances and running the ambulance crews that way. I can only imagine, I wish we could take one of those medics from the late 80s where the stigma kind of was, is you guys aren't the fire department. We're doing this and you're with us. To today, where I try to think all 3 battalion chiefs are medics, a majority of the lieutenants are medics, all 3 captains are lieutenants, or all 3 captains are paramedics. We've cycled through now where it's EMS is 80% of our call volume. Nationwide, it's 80 to 85%. Nationwide, it's definitely where our career, our service is going to. Is having those old medics, or still technically current medics that are just not practicing on an ambulance, on those calls with you. I remember hearing stories from old medics when I was a medic on, boy, you'd never have called a truck on that. That'd been a death sentence to you.
Yep.
Where now it's, are you kidding me? It turned into a cardiac arrest. You know, you have to have the personnel. And part of it is because our scope of practice has grown so much. I can remember in my time onto the ambulance, we didn't have Lucas devices. So there's a dedicated person right there to only compressions. Our drug policy, or our drug protocols were somewhat similar, but I always try to keep up and watch how drugs drop off, or you add drugs, or you change the timing on drugs, which is always interesting. Where do you see the paramedic program in the fire service going from here?
I see more consistency. So ambulances will continue to get called out, and like in Waterloo's specific case, people have transitioned through the promotional process. You start out tailboarding and riding the ambulance if you're a medic, and then moving up from there. But as soon as you are no longer practicing on an ambulance all the time, you're on a fire truck, you still have those skills and that experience. So especially in Waterloo's case, where you have just such a large, like a very high density of experienced personnel responding, because on any given call you could have 5 paramedics, or no longer frequent paramedics, but they still have the experience to draw on, so they can recognize sick, not sick, assist in skills, or at least provide their knowledge. I see that moving forward as paramedic being much more common and just having that knowledge base across the board to improve patient care. As far as what more services that paramedics can provide for the community, I don't see necessarily. I see more advances in technology, better 12 leads specifically in cardiac events, whether they be cardiac arrest or just a simple chest pain. I say simple because it's the most common. A lot of people have chest pain, and it absolutely is a reason to call 911. Don't skip out on that. But just having all of the technology progress. I've said since the beginning, I wish, considering how frequent we see Bluetooth used, I don't understand how we don't have Bluetooth leads just to get rid of cables. If there's some way we could just get rid of cables.
Right. But then what's the lieutenant going to do other than just unstring the cable? That was my go-to.
Oh, he documents. Lieutenant is the documenter, which is extremely helpful. Have somebody watching the clock, documenting times and everything. It makes the recall on our reports much better and much more accurate.
Let's keep going with that a little bit. Let's talk about let's call it a chest pain call. It is one of our most common calls. From the moment the tone comes in at your station until you drop the patient off, talk me through what happens.
Get the call, heading there, I hear the patient's age, sex, and just based on that, I can already make some inferences. Men are more likely to have cardiac events, but women are more likely to have masked cardiac events. Their chest pain doesn't present stereotypically. Then I'm also thinking whether or not they have history of a cardiac event. Dispatch often gets that information and gives it to us. Like if they've had myocardial infarctions, what a true heart attack, they'll bring that up. Or if they have history of bypass, dispatch is pretty good about getting a lot of details. We don't necessarily need to hear all the details on the en route because the patients will tell it to us as well. But just having that information going into it can be helpful. Once I get there, see the patient sick, not sick, based on their presentation. And then sick, not sick, to break that down further, can be conscious, alert, and oriented. Are they awake, unconscious, or what range in there? Because there's multiple different levels of consciousness that you can base their presentation on. Then airway, breathing, circulation, patent airway, what's their breathing like, and then I check the pulse once I go hands-on. If it's rapid, irregular, all variations that could possibly present with the heart, then take that into account. And then from there, going down the chest pain protocols, baby aspirin, establish an IV, give nitro, and do a 12 lead. 12 lead, multiple angles of the heart, looking for ST elevation and ST depression in reciprocal leads, and then relaying all that information that I've collected from the patient history, medications, and what they're currently feeling, relaying all of that to the hospital via radio report and the electronic transmission of the 12 lead, and then transporting that patient to the hospital. And chest pain can present in multiple ways. A lot of the time, whether or not we go lights and sirens to the hospital with the chest pain is strictly off the 12 lead. If the 12 lead is very obvious of ST elevation in specific leads with reciprocal changes, we give nitro trying to reduce the pain, dilating the vessels and hopefully getting blood flow to the area of the heart that is causing the pain, and then rapid transport and getting them to the facility that they need to as quickly as possible.
One of the questions I get quite often is, why does a fire truck go with the ambulance to calls?
To bring back your point earlier about it turned into a specific call, why'd you call a truck? Well, it turned into a cardiac arrest. You just don't know. Mm-hmm. Somebody's heart, it can be causing chest pain, and that's a reduction of oxygenated blood to the heart vessel, and who knows when it's just going to become completely occluded and that heart is going to say, no more, I'm done. And it's just helpful to have the 3 extra personnel, because to call a truck after the person has already gone into cardiac arrest, we're already a step behind, because now we have multiple things that need to be done, putting the Lucas on to start compressions, the patches for electrical defibrillation, starting an IV, giving cardiac drugs. That's a lot of steps, and it's extremely helpful. And that's if the patient is already in the ambulance when they suffer their cardiac arrest. A lot of times they're not, that we could still be in the house. I've had patients feel fine, they're fine. We talk them into going to the hospital, just get checked out to explain why they went unconscious. He insisted on walking, and he wanted to walk to the cot. We helped him. He laid on the cot, and then he went into cardiac arrest right there. And I had already disregarded the truck, so I had to call them back. And it just set us just a few steps behind to where we got a happy outcome of the whole situation. But it could have been better if the truck had been there, which that was my own decision at the time. Patient didn't seem sick, full assessment, sent them on their way. We stayed on scene for probably 15 minutes after that, trying to talk him into, because he didn't want to go at all. And finally talked him into going, and then got him on the cot, and I'm really glad I talked him into going instead of leaving and then it happening, and then we're even further behind to where we don't get the good outcomes.
Right, when you're called back 20 minutes later because they're no longer responsive.
Yep.
I'm gonna ask you a question that I probably know the answer to. What's your least favorite type of EMS call to go on? The most stressful. Let's say it that way. The most stressful way.
The most stressful, I would say, is non-compliant. Non-compliant meaning not following medical recommendations from their primary care doctor for a psychiatric issue. Strictly speaking, medical issues or psychiatric issues are making up a much larger and larger of the call volume on a typical day. The general non-compliance, whether that be not taking your medications, not seeking the help that you need, denying the fact that somebody heard the patient say that they were suicidal or that they wanted to hurt themselves, and then we show up and then denying that and just being confrontational almost to the point where, as far as medical standpoints, there's not really anything medically I can do, but I need to communicate with them. Communication, just in general, with those particular patients can be a little bit more challenging because they are non-compliant. They do not want to deal with it. They don't necessarily want to seek help, or they're just pulling back to where they're not forthcoming. And it's just a little bit more of a struggle because we have responsibilities, because if someone is suicidal or they said or they do have thoughts, our responsibility is to get the patient to where they need to be. They need to talk to a specialist. They need to talk to a psychologist, social worker. They need to talk to somebody. And I almost see myself as kind of a middleman to where I don't necessarily want to say things that could push them further down the path, but I want to get them to where they need to be so that they can see past this episode. Because people are suicidal. It can come and go. It can be a stressful situation in the moment. But I just need to get them to a better place, talk to somebody who can get them through whatever they're going through and put them on a better path. So that's where I see as one of my bigger challenges. That and just any medical call where there's a language barrier. Those are always... That's a separate challenge, and understanding that the English language is decent, but not the greatest. So as soon as you throw in a language barrier, communication just becomes the most difficult part of the call, just figuring out what's going on with someone that doesn't speak English. It's a lot of almost sign language. Pointing to the area or knowing just a handful of keywords. Like, I'm trying to think off the top of my head. At one time, I knew pain in 4 languages, but I think I've fallen off on that. But that's pretty common. I almost think it would be very helpful
Right.
if we all had just keywords in different languages, even on a card. I would probably pull that card out pretty often if I had it.
One of the biggest issues anytime we have those psychiatric patients, suicidal patients, is they don't trust anyone. And they have to get to a point where they at least can trust us a little bit. How do you get to that point with them?
Patient rapport. So a lot of the situations that would cause someone to be having the situation they're in, the stressors, a lot of it is family, a lot of it is social, a lot of it is just removing them from the current situation. Because when we get called to these, it could be police could be there for a domestic situation between a husband and wife, and there's kids involved, to where one of the parties just said a comment that they wanted to hurt themselves, and then police have the same protocol that we do, that you need to talk to somebody about this. Easiest thing to remedy that situation, or at least get it going in a better direction, is just removing them from the area, removing them from the cause, whether the stressor that caused them to say those comments was family, just general situation, just removing them from that, and then having an honest conversation about what they want and what can best help them get through the situation and move on after the fact. So that's typically what I see works the best in my case. A lot of the police officers carry cigarettes, surprisingly, is very efficient getting the patient removed, and then a lot of patients will, just to calm them down, get them removed and open up a little bit more. Police seem to really not necessarily fall back, but have that in the ready just in case, and I've seen it work multiple times. Or it just gets the patient to open up, acknowledge the issue, and then I voice my concerns, and then explain the situation that we need to have you talk to somebody. Just explain the situation and seek help. And it's worked multiple times, and I almost wish we could carry cigarettes, because I feel like it might help.
Yeah, that was always my trick as well. A non-smoker, I'm sure you aren't either. You don't really carry cigarettes around, but anytime they would ever, if you could tell they were having a serious mental issue and you were trying to build that rapport, they'd ask if they could smoke a cigarette, and I'd say, yeah, you can, but once we get in the ambulance, you're going to have to put it out, because we have oxygen in there. But yeah, it's almost a switch then. It can click in a little bit of, okay, this guy isn't quite so bad. Gives them a little bit of control, I think, as well, that they can do something. That little bit of health issue of smoking a cigarette is minute compared to what we're really dealing with, was always my thought. And I was always fairly impressed on how fast people can smoke a cigarette walking from a front door to an ambulance.
Yeah, just one big inhale. For not having smoked, it seems like, well, and everybody's does it differently, but just I watched one guy almost do it in 2 pulls, and to me that just made my lungs hurt just watching it. But it just moved right up very quickly. And thankfully, because I was the other concern is you might upset him if you ask him to put it out prematurely. So, but take an extra minute outside the ambulance, because as soon as you step in, well, at that point, if you're willing and cooperative to go, jump seatbelt, get moving.
There's a good example of they're sick in their own way, but when they're with you, they're safe. They're not going to crash. They're not going to do anything while you're there with them. So you do have that little bit of discretionary time of, we can get there. It's certainly not going to be a lights and sirens call to the hospital, just where you can aggravate them even more. It's going to be, placating is probably not quite the right word, but we're going to work with them to give them the best outcome. And sometimes they're not their own best friend. They self-hurt, whatever. We want to make sure that they don't do anything along those lines, or we agitate them to those points. Are you married?
Yes.
Any kids?
No kids. We got 2 dogs. Little pit bull named Gilly, big German Shepherd named Joyner, and a couple weeks ago we picked up a cat.
No.
So
How does the cat fit in with the two others?
surprisingly well. My parents have the most cat-like dog, and I ended up with the most dog-like cat.
Oh.
The cat just wants to be around people, doesn't hide.
That answered the question for me a little bit ago when I asked you what your least favorite kind of call was, and I said I thought I knew the answer. I thought the answer would be any type of little kid call.
Oh,
But I think
kids
maybe
are different.
Yeah, they're different. But I think you don't have that.
Yeah, the parental.
Yeah, the parental
kind
kick
of.
in yet.
Nope.
Those were always my least favorite. And I remember to this day, and it was a call that ended up well. Was we had a little boy riding his bicycle, got hit by a van, and was in serious shape. Needed a haul, and we needed to do our best work right away.
Mm-hmm.
And he was right about the same age as my middle son at the time.
Ah.
So that, and again, I think he ended up having some sort of surgery. I think he had a bleed, but he came out with zero deficits. It was a great call. He came back to the station to see me. It's the only patient that's ever done that, and I still even feel a little choked up talking about it. So, but I would still put that down as my worst call ever. Everything went perfectly, but the stress level is so high because the outcome is so important.
That and the outcome is so important just because it is a younger individual. I almost feel that an added stressor is the uncommonality of kids, because kids they are the healthiest population because they don't have the longevity of living where you don't have the time to develop any sort of conditions. But the frequency, we don't see kids. And unfortunately, when we do see kids, a lot of the time it is a traumatic injury. Traumatic injury even makes up a much smaller amount of the call volume. Mm-hmm. So it's just a combination of it's a traumatic injury and it's a child. So that crossroads kind of leads to a very, very, very small amount of the actual number of calls to where we don't see it very often, so we're not thinking about it as much. Mm-hmm. So we're not mentally prepared. That'd be kind of one explanation of why it might. But also, being a parent, you're probably a little bit more concerned in general, especially being the same age as your son at the time. That would definitely raise the heart rate a little. Typical call volume, well, that kind of varies on the season. Not so much surprisingly, but during the summer, a lot of people are active. A lot of people are out and about. During the winter, you have flu season. More recently, COVID. Just in general, it's more people are suffering with COVID, with it having health problems. It's more common during the winter as flu season. But on any given day, on average, I would say it's between 6 to 10, I would say would be a fair average. But depending on which territory you're in Waterloo specifically, that number can drastically change. Mm-hmm. There can be a very busy ambulance that just has one day where nothing happens in their territory. It happens surprisingly often two specifically. One is very consistent with the number of calls, but I would say more based on the season is what determines how many calls actually come in.
What's your downtime look like when you're at the station between calls?
Downtime is kind of a combination of individual study, particularly refreshing on protocols, current studies for whatever medication. I do find myself looking up medications pretty frequently just as a refresher, keeping up on all of the suffixes of medications because I can generally group them into one group of medications that treat a particular problem. So having the ability to just look at someone's drug medication list and knowing the condition that they most likely have is helpful. Refreshing that. Currently, I'm actually expanding my study into a little bit more of the driver or operator and the pumping side. So I'm going through that textbook, spending time on that, and then talking with some of the other guys, whether it's just casual talk, just to pass the time a little bit, or some scenarios, or running through the fire truck, just pumping. Just having that knowledge that when I do get the opportunity to be on the truck, being able to be proficient as a firefighter as well as a paramedic when I get the chance to be.
What do you do with your time off? How do you stay mentally healthy? How do you stay physically healthy?
Well, mentally healthy is doing things completely separate from Waterloo Fire and paramedic specifically. So a lot of those calls can be just taxing. A lot of the repetitive, staying busy all during the day on those days, going home and just not being busy. Just little rest, relaxation, little separation, trying not to think about work at all. So picking up hobbies, doing some home improvement things. I enjoy my time. Can't really do it now with the seasons kind of less than ideal, but I enjoy disc golfing.
Oh, yeah.
So playing in all of the parks around here, trying to improve my form and specifically my putting, because I'm terrible at it. But trying to challenge myself to improve that. Plus it's some simple cardio, going walks in the woods with the dogs. So
Yeah, that unplugging is what
Yeah.
I'm hearing.
Yep, absolutely. But on the physical side, I've been actually doing a workout program now at the YMCA. Completely separate, pretty much 100% weight training. My goal at the beginning of it was to try to get up to 170 pounds. You laugh. Everybody laughs at that. Just to do some of the firefighting skills, just having a little bit more muscle mass and weight would definitely help in a lot of the situations, and just having general strength. One thing in particular is pulling the hose out of the hose bed. A lot of those are higher up, and just having a little bit more weight to throw into, getting it out on the first pull
Well, I
is
think
definitely helpful.
People in general don't understand is firefighters have to have really good cardio, which they understand, but we also have to have some mass. You can be super strong, but if you're 140 pounds, that hose line is going to throw you around. You have to have a little weight behind you to do it, and it's a sliding scale, certainly. That to find that equilibrium that works for you is always an important part.
Well, and it always, it was like when I first got my fire gear right after getting on the department, my wife wanted to try it on, and she didn't realize how heavy it is.
Yeah.
And just having that weight, and that wasn't even with the SCBA, which is another 32 pound, 32 give or take.
Yep, our new ones, I think.
And just being able to function with everything is bulky gloves, and just being able to still maintain the movement and strength has been a challenge for me specifically, because at 160 right now, I'm pretty much carrying 30% extra weight on top of me, and then still needing to function to the level that I need to for the job has been a challenge. So that's why I've been trying to bulk up as best I can over the last year.
Well, just keep eating firehouse meals and we'll get you there.
Oh, yeah. Goop.
Goop, if those that are unaware,
Goop should get me there.
It's kind of like tater tot casserole, but you don't want to call it that.
Yeah. I was going to say, you might ruffle some feathers just by saying that.
But if you had to put it in a category, it'd be that. It's very high carb, very high calorie, and very good.
Yes.
And you can eat a lot of it once you get accustomed to it. So keep on that, and I'm sure you'll be just fine. Adam, anything else that you want to talk about?
Not particularly.
Well, I appreciate you coming in. Again, guest today has been Adam Boyce, Waterloo Fire Rescue, been a paramedic, been a firefighter. It's been a pleasure. Thank you.
Thanks, Bill. Glad to be here.
I really enjoyed my part in the interview. No matter what your line of work, it's always refreshing to talk to a younger person and see their passion and let it renew your own. Adam may have said some technical terms you may be unaware of. An EKG is an electric reading that our cardiac monitors give of a patient's heart activity. A lead is the little sticker with the wire connected to it that tracks the movement. Paramedics typically begin with a 4-lead EKG, which require 4 stickers. A more advanced EKG is a 12-lead, which involves adding an additional 6 stickers. Well, that's our show. The show doesn't really rely on me, though. I'd like to thank my producer, Angie Beck, for knowing what buttons to push. Our original music was composed and performed by Caleb Martin. I'm your host, Bill Beck. Until next time, get out there and have your voice heard.